Good evening and welcome to Infants Nutrition Series webinars. The theme for this educational webinar will be the Allergy Expert in Action, Alexa. This webinar is offered by Sespagan and is supported by Nutricia Specialized Nutrition. This webinar has been accredited 3 CME points by the Saudi Commission for Health Specialties in Saudi. Since this is a CPD accredited event and as per the accrediting organization requirements, please note that the credit certificates will be provided only to those who participated fully in the activity and completed its requirements. If a participant failed to attend the activity in full, then he will not be eligible to receive credit points assigned for that activity. You have a chat tab that you can use, but please submit your questions using the Questions tab that you can see on the right of your screen during the presentation. You can send your questions while the speakers are presenting, and the speakers will then reply to as many questions as the time will allow. During the presentation, we will post poll questions. Please reply to them in the poll tab to the best of your knowledge. To start this event, please welcome our chairperson for this evening, Dr. Dafer Al-Shehri. Dr. Dafer is a pediatric gastroenterologist consultant and the head of the pediatric department in Najran University. It is a great pleasure to welcome Dr. Dafer to join us this evening. Dr. Dafer, up to you.
Thank you so much, Helen. First of all, I would like to welcome you all to this event, which is presented by Saudi Association for Saudi Society for Pediatric Gastroenterology, Hepatology, and Nutrition. My name is Dr. Dafer Al-Shehri. I'm an assistant professor of pediatric gastroenterologist at Najran University. Actually, it's great pleasure and honor for me for opening the second webinar of Infants Nutrition webinar series, which consists actually of 4 webinars, which had been started early this week. We are delighted to have everyone joining us here tonight. I hope that you will take the time to learn and interact with our distinguished speaker, who shared their thoughts and insights about infants feedings and nutrition. I would like also to extend special thanks for the head of Scientific and Professional Development Committee at the Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition, Dr. Ali Al-Muhadib, who spent a lot of time and great efforts to arrange and organize this webinar series. Also, special thanks for the President of Sespagan, Dr. Muad Traiki, for his continuous support and all members of Sespagan. I would also like to thank and recognize our platform sponsor, the Nutricia company, for their continued support and commitment to this scientific program series. Our programs tonight composed actually of 2 lectures, 30 minutes each, followed by open discussion. So if you have any question, please don't hesitate to post it in the question field. And for your information, as you heard before a while, this event will be accredited by 3 CME hours. The first speaker tonight is Dr. LOIE GORONFOLAH, who is Assistant Professor of Pediatrics, Allergy and Immunology at King Saud bin Abdulaziz University of Health Sciences. He's consultant in Pediatrics, Allergy and Immunology at National Guard Hospital, Jeddah, Saudi Arabia. So he will talk about the gut microbiota and allergy. Dr. GORONFOLAH, please come to the stage. You are welcome. The mic is yours now.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh jami'an. I would like, before I start, to thank the organizing committee, Sespagan, and Mr. Chairman. Thank you very much for the nice introduction, and as well as Nutricia for sponsoring this event. Gut microbiota and allergy is a topic in which we noticed recently as it's receiving a lot of attention for the science of it as well as for the myth of it as well. Here are some of the things which I will go through. I will talk about the global rise in allergy. Definitely the nutritional management of infants with cow milk allergy will be left for my colleague Dr. HASOSAH, but I will just brief 1 or 2 slides to introduce the concept of microbiota and the role of microbiota in modulating the immune system. and if there is any evidence about the role of nutrition as well in the gut microbiota, and what is the new strategies in allergy management. Recently, we have observed and noticed that allergy overall is increasing rapidly, actually not only in the developing countries, in worldwide. A few years ago, in my clinic, we used to see 1 or 2 cases of new food allergy per month. Now we are seeing 1 or 2 per clinic, which is 2 to 3 times per week. And that's been populated and being published in many studies that there is a 30 to 40% of the worldwide, they suffer from sort of allergy. Out of these 30 to 40%, there are 5 to 8% of them, they are infants and young children. And if we subtract and we look at food allergy or exactly cow milk allergy, that constitute 2 to 5% of that population. This has been observed in many countries. If you look at the Middle East, there are different studies, different observational studies, which says that asthma, eczema, and allergic rhinitis are on the rise. There are different studies. If you look in Saudi Arabia, there are some papers saying asthma constitute around 24%, eczema 10%, allergic rhinitis 25%. The same observation been noticed in Oman, Qatar, Kuwait, UAE, as well as Lebanon. That's not only us. It is a prevalence. It is allergy. It's on the rise. There are many studies in different countries saying that more patients are suffering from not only allergy overall, asthma, as well as eczema. There is a famous study called GOSTO in Singapore. It's a 5 years. They found that at the age of 5 years, there are 35% of the population, they have a positive skin prick test, which means that they are sensitized by an allergen. And 26% they have some sort of eczema, and 22% they are of their 5 years old population, they are wheezing and they are using some sort of nebulizers. 40% of that population has some sort of rhinitis. In the Arabian Peninsula, 8 to 23 of the population, they have sort of pediatric asthma, as well as 7 to 25% pediatric eczema, and up to 30% allergic rhinoconjunctivitis. If you look at the graph on the left, you will observe the rise of raising the rate of allergic diseases from the 1950s to year 2000. That's not only it. We are also observing the aggressiveness of the disease is not only a prevalence. So look at this graph. This is the number of children who were admitted because of food-induced anaphylaxis. When you compare 2006 to 2011, you will definitely observe that there is a trend of hospital admissions of children in that population among that Italian study. So we are not talking about a prevalence, we are talking about an aggressiveness of the disease itself. And this definitely lead to, of course, we are talking about school absence, severity of the disease, and hospitalization. This is the famous atopic marsh slide, which we all know about. I will go through it. Allergy or atopic diseases are a package. So most of the patients, it's a genetic tendency to develop a certain group of diseases. It usually starts with food allergy in the first year of life, plus minus atopic dermatitis, followed by allergic rhinitis and asthma later in life. This is a schematic representation that once the child developed, or the genetically predisposed child developed atopic dermatitis or food allergy in the first year of life, he or she is more likely to develop other kind of allergies like allergic rhinitis or asthma later in life. The consequences, if I can say, or the burden of allergy is not only symptoms. We are talking about definitely physical consequences. We are talking about financial issues. There is an increased medical and health costs, as we know, and the social issues of food allergy in specific is being published on many studies that families with one child who had food allergy, they are isolated, they fear the future, they are socially withdrawn, and definitely the psychological impact of, we are talking about food allergy on the family, and of course the distress of the child and the impact on quality of life, as well as the amount of bullying those children are receiving if they were diagnosed by any kind of allergies in school and in their day-to-day life. So the management, as we know, there are so many studies, definitely Dr. HASOSAH will go through that, talking about the guidelines for management. We practiced for so many years, we practiced that food allergy means one, no exposure. You have to avoid that allergenic item in hope that your immune system can develop some sort of tolerance, and that may lead definitely to no harm. So that's been the practice for years until recently, when this study came up, and it was a, I would say, science shifter from the allergy avoidance to early life exposure and the consequences of early life exposure and immune tolerance. I guess most of us went through that, knowing that those children who were exposed to the food allergen in early life in different ethnic backgrounds, they develop less allergic diseases or food allergy in the future. That lead us to think about, okay, what is the current approach in the management? Let's take a step back and look what is our current approach. Our current approach in management, you have to have definitely allergen avoidance, and you have to bring up an alternative. The alternative need to fulfill two criteria. One, that alternative need to be less than 1% immune reactive. So less than 1% of those children who receive that alternative should not react to this new alternative. And 90% of the children who receive your alternative needs to tolerate that, which give us a 95% confidence interval. This is the current approach in the management. And if you look who are the formulas in the market which fulfill these two criteria, you will see either we are talking about the extensively hydrolyzed formula or the amino acid based formula. Both of them fulfilling these criteria, which is less than 1% immune reactive, more than 90% toleration, and definitely the avoidance is the top management of that, and the human milk is the gold standard management approach for children with cow milk allergy. We experience that we experience sometimes failures, and this is part of medicine. But if you look into the failure, why do we fail? We have to look into the cow milk composition. And there are not only two proteins which we are talking about, the casein and whey. There are so many proteins which we may overlooking and not considering that in our approach or in our management. That brings us to how do we train our immune system? What is the role of gut microbiota in training our immune system? There are very important organs which develop over the first 1,000 days of life. Those organs are not fully developed during birth, but they mature as the child grows up. They mature over the first few years of life. And you know that newborn have a limited capacity to initiate any immune response in their early life. So that's what brings us to the importance of those 1,000 days of life. And the thymus, as we know, is one of the important organs of our immune system. We have what we call the gut microbiota. The gut microbiota, or the gut itself, it is the largest immune organ. the largest immune system or immune organ in our immune system are the gut and the skin. 70 to 80% of our immune cells are located in our gut, and those immune cells constitute most of our immune response. It is definitely that amount of immune cells is influenced by the amount of microbiota which we have in the gut, which in some studies constitute around 100 trillions of bacteria available in our gut. And we know that it is one of the most neuron supplied organs, which contains 100 millions of neurons. And if you look at the mucosal surface of our gut, it reached to 32 meters. So by that we know, and we are sure that the gut play a very critical role in developing, and not only developing, sustaining our immune balance. This microbial interaction with our immune system, what we call it the crosstalk. The development, as you know, of the gut microbiota happens over time. It's exactly like any organ. It happens, it starts from the early life. It goes with time until the child reach the age of 3 years. And that interaction between the microbiota and the immune system lead to what we call it the crosstalk between growth microbiota and our immune system. We know this, and it's been studied in many papers, that there are some factors which influence the development of gut microbiota. If you guys heard about the hygiene hypothesis, we are talking about the same concept. Why we are observing more and more cases of allergy. There are studies or there are some papers saying it is about the gut microbiota. The hygiene hypothesis. The cleaner we are, the more allergy we are having, which goes and fall beyond these factors. So what are the factors which lead and influence the development? Mode of delivery. We have seen or observed that it's been observed that children who are born to vaginal delivery, they have more gut microbiota than those who are delivered by cesarean section. Gestational age, early life infections, feeding patterns, as well as using antibiotics in the early life, as well as some genetic system and maternal factors. So these factors play a very important role in the influence of gut microbiota in early life. If you look into what is exactly the window for opportunity that we can interfere, and at least we cannot manipulate that gut microbiota, it is in the first 1,000 days of life. That is the life where is the microbiota develop and grows and interact with our immune system. I will talk about the dysbiosis in a minute, but any manipulation, or let's say any interference with the gut microbiota in that period of time lead to what we think of allergy and other diseases, and that extends to adult life as well. Let's have a look at the healthy as well as the when I say dysbiosis, I mean manipulating the gut microbiota in early life. Healthy gut microbiota, it is those children, as I said, who are delivered vaginally, breastfed in the first 4 to 6 months. You have a higher level of certain bacteria, which we know most of them are the famous one, Bifidobacterium, Lactobacillus, and others. But if you interfere with the gut microbiota in the first 1,000 days, you will have, or we observed, or it's been observed, that there are other varieties or other patterns of bacterial growth, like Clostridium difficile, Staph aureus, and E. coli. And that is been observed in many studies with the manipulation or dysbiosis in early life, like using antibiotic early in life, and other factors which lead to or change our gut microbiota. Again, as I said, there are many studies which looked at if you disturb that microbiota in early life, there are some allergy development. And that's not only food allergy we're talking about, asthma, atopic dermatitis, and other allergic diseases. So what is the role of nutrition in gut microbiota? Is there a new approach to allergy management if we know that? So we know that avoidance is the current practice, and it is what we are practicing so far. But putting in mind the LEAP study, that makes us think about maybe there is another way to approach children with food allergy, which lead to tolerance development. So if you want to have a proper food, let's take cow milk allergy, a proper management. So we need those factors. We need, of course, we have to have a controlled protein exposure. Remember the LEAP study. So you need exposure, definitely, but it needs to be controlled. It doesn't mean that the child go and drink a straight milk. No, it needs to be controlled protein exposure. And we need to contain or maintain that gut microbiota. Doing that, definitely, if you have that, you will have a fast and effective symptom resolution, modulation of the gut microbiota closer to healthy breastfed infants, and this is going to be the right environment for the immune oral tolerance development by doing that. The golden standard, the golden model for us to look at any alternative is the breast milk. And the breast milk is the natural product which trains our immune system. If you look at the breast milk and cow milk allergy, there are what we just talked about. We talked about two factors. We talked about controlled protein exposure and maintaining gut microbiota. So how that happens in breast milk? Breast milk, there is definitely a controlled protein exposure to harmless protein. And those proteins are found in breast milk in a very controlled manner, which definitely lead to no allergies. Let's look to the other side in breast milk, the gut microbiota. We know that there are, I will talk about the oligosaccharides, or what we call it prebiotics. It's a prebiotics or oligosaccharide. It is used to feed the beneficial bacteria, and there is definitely a beneficial bacteria, what we call it probiotics, which we talked about the crosstalk and the immune tolerance. Breast milk is a unique product, which I think if we keep studying for years and years, we will keep discovering new items every day. But let's look at those items or those components which are related to our immune tolerance. We know that there are lymphocytes, macrophages, which plays a very major important role in our immune system against infections. We know that they have antibodies, cytokines, which plays a very important role as well in our immune tolerance. One of the bioactive components in breast milk are the bifidobacteria, lactobacilli, and definitely there are others, which we talked about. These, the microbiota's elements or bioactive components lead to the immune tolerance or immune interaction. So we believe now that if you expose the child early in life to bacteria, for example, or harmless bacteria, that makes our immune system works better. If you expose the child to allergenic proteins or controlled proteins early in life, that will lead to more tolerance later in life. The oligosaccharides, there are human milk oligosaccharides, which used to feed those live bacteria. And we know there are other components in the human milk, like fatty acids, protein, minerals, and vitamins, which are there to look at. So the prebiotic effect, it stimulates the growth and activity of those bacteria, which lead to the oligosaccharides, which lead to the direct effect on immune system. And not only that, those oligosaccharides can block the route of infection. This is what we think of the human. This is the human milk oligosaccharides. 90% of them, they are what we call short chain, and 10% of them are long chain. The prebiotics are oligosaccharides. The pattern or the composition or the component are what we call them SG GOS and IC FOS. The ratio of SG-GOS to IC-FOS is 9:1 when you compare it with the SC-FOS, IC-FOS. That ratio is the closest to the human milk oligosaccharide prebiotics. And that's why, if you look at most of the study, a lot of studies which looked at the prebiotics and their effect on many future life diseases, they looked at that composition, the SC-GOS and IC-FOS. The most of the studies looked at the composition because it is the closest to the human milk oligosaccharide. The European Scientific Committee on Food in 2006, they indicated that this compound, which I said about the GOS-FOS mixture, is the only prebiotic which is allowed in the infant formula based on the clinical studies in different number of studies. And it's been evaluated over years that this composition, GOS-FOS, is the closest to human oligosaccharides, which definitely lead to or help in the growth of the microbiota. There are systematic review looking at the effect of prebiotics and eczema early in life. If you look at the systematic review on those studies shifting to the left, it favors the prebiotic. Those studies which are shifted to the right favors the placebo. And this systematic review was looking exactly at eczema. And this one was looking at infectious diseases overall in healthy infants and children, and the role of prebiotics there. There are more than 30 clinical studies, and I believe that goes up by the minute. There are more than 55 scientific publications talking about that ratio, which we are talking about, 9:1 GOS-FOS ratio. That ratio in most of the studies showed that there is, some of studies showed that there is a reduced incidence of a lot of allergic diseases. Most of the studies looked at eczema in specific. And the ones I showed you, it talks about the future bacteria and infections, as well as the stool frequency and consistency. Human milk, as I said, it's a unique product, which if you keep studying, you will discover things every day. And if you look at different races, different breastfeeding mothers, you will see there is a big variability in the microbiota, or in the harmless, or what we're talking about, bacteria available in the breastfeeding. And most are the commonly isolated bacteria from different species are the bifidobacteria and the lactobacilli. And if you divide the bifidobacteria, there are 3 different species. Most of them, they are what we call Bifidobacterium brevi, 50%, 25% Bifidobacterium bifidum, and 25% Bifidobacterium adolescens. So if we summarize what we know about the benefits of prebiotics and probiotics in allergy management in different studies, we know there are some studies which shows that prebiotics can reduce the risk of eczema in infancy, as well as prebiotics may help you outgrow the IgE and non-IgE mediated cow milk allergy in the future. I use the term symbiotics, which means combining pre and probiotics in the same product. There are some studies saying that if you combine the pre and probiotics, it is very important, or it can improve the clinical symptoms, in specifically IgE-mediated atopic dermatitis. And we have to remember that it is a strain-specific, and it is a dose-specific, like what we said about the GOS-FOS as well. I will share the in the last slide, there are many studies, clinical studies, talking about symbiotics combining pre and probiotics in cow milk allergy. And the most famous one are Harvey and Burks. They looked at maybe you can different populations, but most of them, they are cow milk allergic infants, definitely different ethnic backgrounds. Most of them showed that there is a comparable results in growth parameters. Exactly, if you add it to the amino acid based formula, they have the same effect as the amino acid formula, the plain amino acid formula. On the other study, it shows a normal growth and effective management similar to the amino acid formula. And the SCORE AD, which is the assessment tool we used in analyzing patients with atopic dermatitis, it's been exactly the same between both groups. And it was also tested to contain the same amount of bacteria as we talked about. If I want to summarize what I was talking about or giving you some take-home messages, by 2050, allergies will be affecting more than 40 billion people globally. We used to approach food allergy in a way which probably needs to be looked at again or observed again. We have to move from avoidance to tolerance development. Microbiota is a very important role in our immune system interaction and immune system development. Early life interference and early life interference with the gut microbiota lead to development of unwanted bacteria, if I can use that term, which is called dysbiosis. One of the things which we need to look at and definitely study is the effect of gut microbiota remodeling and the effect on allergy outcomes from the long-term perspective. Thank you very much. Thank you, Mr. Chairman, and I will leave the mic back to you.
Thank you so much, Dr. for this nice presentation and demonstrations. We learned a lot, and there is some interesting topics actually we came across. Thank you so much. We'll go to the second speaker, Dr. Mohammed HASOSAH. Dr. Mohammed, he is Associate Professor of Pediatrics. He's a pediatric consultant gastroenterologist, head section of Pediatric Gastroenterology Department at King Saud bin Abdulaziz University for Health Sciences in National Guard Hospital at Jeddah. Who will talk about update in allergy management. Also, there is some interactive cases scenario included in his talk. Dr. HASOSAH, you are most welcome to come to the stage, please, and mic is yours.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Kull aam wa antum bkhair. Thank the chairman for this introduction, and thanks for Saspican for this invitation, and also thanks for Nutricia for this sponsoring, and a special thanks for attendance who's going to listen to my lectures. So I'm going to talk about the update and management of cough milk allergy. So my objective and my outline is briefly about IgE versus non-IgE cow milk protein allergy. So how to manage cow milk protein allergy with different guidelines. Then what's the efficacy of hydrolyzed formula, and what's the efficacy of extensive hydrolyzed and food malabsorption. And on include of these, there is a case scenarios. So I need your interaction with me to see how's your practice. Nobody argue that breastfeeding is the ideal form of the infant feeding. Believe me, not only these societies, including WHO, SPCAN, NASPCAN, American Academy of Pediatrics, all of the societies that breastfeeding is the ideal form of the infant feed. So my questions or my case scenarios, we'll start by this one. This is a 3-month-old boy is seen in your clinic because of the skin rash and eczema following ingestion of cow milk. Which of the following would support diagnosis of IgE cow milk protein allergy? A, is it delay onset, days? B, it's harder to diagnose, oral challenge. C, no validated test. D, persistent beyond year. So you have to voting and polling 20 seconds and to see the answers.
Yeah, the polls tab is on the right, beside the questions tab. Please, you can go through it to see the result, please, from the audience.
You have 20 seconds. I'm not testing your knowledge. I'm seeing your practice. How's your practice? Okay. Is it 20-second finish, Dr. Dhafar?
Oh, yeah, now it's 30 seconds now.
Okay.
Done.
Done?
Yes.
Okay. Now, most of you say that 36% no validated test and 28% persistent beyond year and 25 is delay onset. So I think there is some overlap between that, and the answer is persistent beyond 1 year. So I think validated test will be there, and the next slide will explain to you why the IgE mediated is persistent more than 1 year. So cow milk protein allergy is one of the most common food responsible for allergic, approximately 3 to 5%, and Dr. LOIE gives detail about this prevalence. And we should remember that one third of this cow milk protein allergy will suffer from multiple food allergy. 9% will suffer from anaphylactic shock. 5% is eosinophilic esophagitis, and 1% with the protein-induced enterocolitis. Regarding my case scenarios, this is how to differentiate between IgE-mediated and non-IgE-mediated. So 3/4 of the cow milk protein allergy is IgE-mediated. It's usually quick onset, usually within hours. Sometimes you have anaphylaxis, well-defined mechanism, easier to diagnose. There is validated tests that including skin prick test and others, and persistent beyond 1 year. While non-IgE mediated, usually 1/4, and usually is delay onset. Sometimes they have eczema, refluxes, and the mechanism is unclear and usually is harder to diagnose. Usually we diagnose it by oral challenge, and there is no validated test and resolved by 1 year. So this is why, regardless if you do IgE specific antibodies or total serum IgE, by these scenarios you can differentiate between IgE and non-IgE mediated. So we'll come to the same patient after investigation. The infant total serum IgE and specific IgE food were normal. So you label the diagnosis as non-IgE cow milk protein allergy. So you agree this is non-IgE cow milk protein allergy. 2 weeks later, he developed repetitive vomiting and diarrhea within 24 hours of ingestion of milks, associated with pallor, hypothermia, hypotension. It looks like septic. So what is the most likely diagnosis? Is it anaphylaxis? Is it food protein-induced enterocolitis syndromes? Is it food protein-induced allergic enterocolitis? Or this is food protein-induced enteropathy? So you have 20 seconds to answer your questions. Go ahead.
Okay, 30 seconds, done, finished.
Finished.
Yes.
Perfect. Thank you very much. So almost 50% of you answered the correct, which is B, food protein enterocolitis syndromes. Usually these syndromes I found several cases present like sepsis-like symptoms in emergency. They start him on antibiotics, they do LP, all of these. So I'm happy that you answered these questions, most of these attendants. So what is the food protein enterocolite syndromes? We know that non-IgE cow milk protein has 3 types. Food protein induced enterocolitis syndromes, F-pipes, we call it F-pipes. Usually the child presented with vomiting, diarrhea, and pallor. And second type is called food protein induced allergic proctocolitis. Usually the child presented with a bloody and mucousy diarrhea and abdominal discomfort. And the third type is usually called food protein induced enteropathy. These children presented with the failure to thrive and mainly malabsorption, anemia, and hypoalbuminemia. So how to diagnose? We have diagnostic criteria for F-pipes due to cow milk protein allergy. At least you have 1 major and 3 minor. The major criterion is the vomiting within 1 to 4 hours of ingestion of cow milk in the absence of the classic IgE-mediated skin or respiratories, plus minor, either second episode of vomiting or repeated vomiting with a different food, lethargy, marked pallor, so you suspected like sepsis and need to emergency for to control adverse reaction, need for IV fluid, and sometimes, most of the time, 90% they presented with diarrhea within 24 hours, and those children or those babies presented with hypotension and hypothermia. So once you have this criteria, you can label the child as F-pipes until proven otherwise. So now we'll come to the scenario number 3. So after starting hypoallergic formula for this child, no more vomiting, and the infant becomes asymptomatic. However, the mom say that his brother has lactose intolerance. So which of the following would differentiate lactose intolerance from cow milk protein allergy? Is it non-immune reaction? Is it lactose intolerance presented with the positive bloody stool? Is it negative reduced substance stools and lymphoid nodular hyperplasia or hypertrophy on biopsy? So you have 20 seconds to answer.
Okay, 20 seconds is finished.
Okay, excellent. So almost 50% of the attendants answered the answer correctly, which is A, non-immune reaction. However, I don't know why 34 or 35% and 14% they answered negative blood stool and bloody stool. So to convince you how to differentiate it between this the answer, to convince you that lactose intolerance and cow milk protein allergy both presented after gastroenteritis. So how to differentiate? Definitely, the cow milk protein allergy presented the GI, skin, respiratories, while lactose intolerance presented with the bowel only for example, pain, diarrhea, and the mechanism of the cow milk because of the immune reaction to milk protein, while lactose intolerance usually is non-immune, reduced ability to digest lactase, and the best thing to do stool test. Usually in cow milk protein allergy, they have positive RBCs and they are becoid diarrhea and negative reducing substances, while lactose intolerance usually presented with negative RBCs and positive reducing substances. Usually endoscopy we didn't do routinely, but we found that in cow milk protein allergy, they have lymphoid nodular hypertrophy, while lactose intolerance, they have villus atrophies. The testing usually exclusion diet maybe take 4 to 6 weeks to improve, while lactose usually is quick, usually 24 hours to see the symptoms improve, and elimination diet, usually cow milk free diet, while lactose in lactose-free diet. And this is very important. Why? Because I found of most of the pediatrician confusing between lactose intolerance and cow milk protein allergy, and simply, even if the mom or any family history of lactose intolerance, this table will differentiate between cow milk protein allergy and lactose intolerance. So, as I said, cow milk protein allergy, they have allergic to cow milk protein, but tolerance to lactose. While lactose intolerance, you have reduced ability to absorb lactose, but they are tolerant to cow milk protein. In between, there are few cases, up to 5%, you may have cow milk enteropathy with secondary lactase deficiency, and those they have allergic to cow milk and reduced ability to absorb lactose. So the management of cow milk protein allergy, well, you have different guidelines. You have SPCA guidelines, you have NASPGHAN guidelines, you have N8, you have DRAGMA, you have British, you have American Academy of Pediatrics of Allergy. So choose whatever it help you for this one. So this is the guidelines, and I'm sure once you pick up anything, so there are no big difference. So the question here, once you have cow milk or cow milk protein allergy, which one I choose? Should I choose soy formula, or partially hydrolyzed formula, or extensive hydrolyzed formula, or amino acid based formula? Now, before to that, let's memorize ourselves what is the constitute of each one. We know that cow milk, usually the protein is whey and casein, while the carbohydrate is lactose, and the fat usually is blend of the vegetable oils and DHA and RA. Lactose-free, similar to cow milk, however, except carbohydrate, usually the carbohydrate is glucose polymers or corn syrup. The soya protein or soya formula, usually it has been soya protein with a corn syrup or sucrose, and the main thing is extensive hydrolyzed formula, usually is casein hydrolysate and amino acid, while the carbohydrate is modified starch and corn sucrose, the same with the vegetable oils and some MCT oils, while the elemental formula usually is a free amino acid with the mainly carbohydrate, corn syrups with the vegetable oils. So the protein breakdown, the protein or the potential additions and antigenicities will be breakdown to from large or intact protein to large peptide to small peptide, the amino acid. So the breaker or the more breakdown the protein, the better or the less antigenicities. So as Dr. GORONFOLAH said, avoidance is better than prevention, and usually extensive hydrolyzed formula hypoallergic usually is one of the option. Almost more than 95% you will be less than 1,500 Daltons, amino acid based formula, partial hydrolyzed formula, and those with the tolerance to show no improvement. So now we'll come to the major questions or the big questions, which is or the most important scenario in this case. Which of the following is the first choice management of cow milk protein allergy? Just cow milk protein allergy. I didn't mention anything without it. Is it lactose-free formula? Is it partially hydrolyzed formula? Is it extensive hydrolyzed formula? Or is it amino acid-based formula? And you have 20 seconds.
Twenty seconds is finished.
Okay, now there are overlap between extensive hydrolyzed and partial hydrolyzed and amino acid-based formula. So this is why the objective of my presentation, this is to show you what the guidelines say that without any confusion. So the answer is C, extensive hydrolyzed formula. Unfortunately, almost 40% of the attendants answer partial hydrolyzed formula. So I don't know why. So now next slide will convince you that all guidelines say that extensive hydrolyzed formula is the first choice of the cow milk protein allergy without any others. So we'll come in detail on it. So see these tables. There are Australian guidelines, there are DRAGMA guidelines, and there is SBGAN guidelines. See, if the cow milk protein allergy presents with the GI symptoms, proctocolitis, immediate food allergy, F-pipes, atopic eczema, the formula choice is extensive hydrolyzed formula. So this is why at least there are agreement between these societies that no doubt that the first choice based on the different studies that extensive hydrolyzed formula is the first choice. Then the second choice will be amino acid based formulas. So there is nothing here partially hydrolyzed formula. So this is why we have to make sure about how to improve our clinical practice to manage cow milk protein allergy. So we agreed that extensive hydrolyzed formula is the first choice, and this is to convince you. American Academy of Pediatrics recommended the use of extensive hydrolyzed formula as a third choice in the case of frothing cow milk. However, if there is failure of extensive hydrolyzed formula, use amino acid based formula. Again, SBGAN, they recommended that extensive hydrolyzed formula is the first choice, unless if the hydrolyzed is not tolerated, use amino acid based formula. The SBGAN recommend that the soya protein formula should not be used in the infant during first 6 of the month, and there is no rule of the prevention of allergic disease, infantile colic, regurg, or prolonged crying. However, in the recent years, there are some data show that there is some improvement in allergic and infantile colic. So now we'll come to the more serious questions. So now we agreed that the choice or the first choice of the cow milk is the extensive hydrolyzed formula. So let's see the scenarios. This is a 2-month-old presented with the vomiting and diarrhea and skin rash after switching breastfed to cow milk. Her mother reported swelling of the lips, and physical examination show severe eczema and severe failure to thrive. So which of the following is the best formula in this scenario with cow milk protein allergy? Is it probiotic associated formula? Is it partially hydrolyzed formula? Is it extensive hydrolyzed formula? Or is it amino acid based formula? You can vote now.
Okay, 20 seconds finished.
Thank you, attendance. Yes, almost half of the attendants answered the questions correctly, which is D, amino acid based formula. I don't know why 35% they answer extensive hydrolyzed and 50% answer probiotics. So this is why in these scenarios, if you have a patient with a different scenario of cow milk protein allergy, it being amino acid based formula is being the choice. So this is why Vandiblas in Europe working groups, they said when you have cow milk protein allergy, divided the severities. If it's a moderate or the severe case. If it is moderate, we agree it is extensive hydrolyzed formula. If it is severe cases, especially like our patient, life-threatening for lips, swelling, severe failure to thrive, amino acid-based formula will be the first choice. And there is, as Dr. LOIE mentioned, that there are ongoing studies that why those amino acid-based formula improve the weight gain. And for this is RCT trials of 109 infant, they give him Prebiotics, which is oligofructose, long chain, aniline, and acetic oligosaccharide and bifidobacterium brevi. And if you see in the right side that the weight for age and the length will be improved with this Prebiotics supplemented amino acid formula. And if you see the scores comparing the controls will be better at week 16. So this is my slide. I always show it to the old pediatrician that once you have cow milk protein allergy, what should you do? First of all, we have to search for clinical investigation, including cow milk protein allergy. If you have any availability of positive test or skin prick test, divide the case. Is it mild to moderate manifestation or is it severe manifestation? If it is mild to moderate manifestation, we agreed we use extensive hydrolyzed formula. If there is any clinical improvement, do oral challenge. If there is any recurrence during this one, usually I switch to extensive hydrolyzed formula for 6 months or until the age of 1 year. If there is no recurrence, usually I reintroduce cow milk. So in a case of the child not responding to extensive hydrolyzed formula or severe manifestation like poor growth, anaphylaxis, severe eczema, or eosinophilic esophagitis, the best choice is amino acid-based formula. If there is no improvement, this is not cow milk protein allergy. So this is why we use cow milk or amino acid-based formula as diagnostic and therapeutic. If there is any clinical improvement, usually we'll do challenge procedures, challenge setting in hospitals. Again, I discussed these issues with Dr. LOIE GORONFOLAH that you need to have sitting, you have to be protocol for that, but most of the centers or especially tertiary center, they are doing in occasionally. So this is gene studies shows that the allergic manifestation 15 years or after 15 years of the intervention with hydrolyzed formula. If you see the blue lines, which is extensive hydrolyzed formula, comparing with the casein, comparing to the extensive hydrolyzed formula with the whey, which is a green, you will see the cumulative incidence of the asthma, atopic or allergic rhinitis, and eczema will be the cumulative incidence will be less, mainly with the extensive hydrolyzed formula casein. And this gene studies has give us good insight about what's the natural history or what's the prognosis of these allergic reaction. So another scenarios in mom or breastfed, what will you do if the baby of the mom is breastfeeding and has cow milk protein allergy? Usually up to 0.5% they have cow milk protein allergy. Usually I should eliminate cow milk products from the mother for 2 to 4 weeks. In my practice, I don't remove cow milk only. I ask the mom to remove nuts, wheat, and eggs, because I will see that it has good response or not. If there's no clinical improvement, so the mom should return to normal diet. If there is any clinical improvement, so I reintroduce cow milk to the mother diet. And if it has any recurrence, usually this is I ask mom to take cow milk free diet and together with the calcium supplement. And sometimes if they are any insisting, usually extensive hydrolyzed formula after breastfeeding up to the age of 1 year or at least 6 months. So this is our practice. Usually we should keep breastfeeding, and please don't stop breastfeeding if you have cow milk protein allergy. So another trick for cow milk protein allergy, please give more times. Give limited times. For example, if you have a patient with cow milk protein allergy with immediate reaction like angioedema, lip swelling, and you want to remove cow milk, give times up to 3 to 5 days to see the response. However, if the child is presented with a chronic diarrhea and failure to thrive, usually give more times, because at least 2 to 4 weeks. For any child with a chronic diarrhea and failure to thrive, and you suspect the child has cow milk protein allergy, and you eliminate cow milk, don't give more times, because if you give 10 days, you will not see the response. So this is why Colisco and GBN presented this one, which may help us that if there's no improvement of the symptoms within these timelines, the cow milk protein allergy is unlikely. So again, we didn't have any challenging in diagnosis. However, we should follow these guidelines strictly. So there are some recommendation for dietary management of malabsorptive enteropathies. So the SPGAN mentioned that infant with the cow milk protein allergy and malabsorptive enteropathy should have formula with high reduced allergicities without lactose and with MCT oils. And this is why Colisco and SPGANs and others mentioned that for infants suffering from mild to moderate cow milk protein allergy, we have to give the cassie-based hydrolyzed formula because it has superior palatabilities. And if you compare between the extensive hydrolyzed formula, usually they have mainly whey protein with almost 85% of the small peptide and very low allergenicities. While the patient have suitable for enteropathy and malabsorption, usually we should give together with MCT oil to facilitate absorption, because up to 41% of the total fat and usually is virtually lactose free. Now will come the most important questions. Which of the following criteria is the feature of the extensive hydrolyzed formula rather than amino acid based formula? So one of these has a feature of the extensive hydrolyzed formula. Is it to support early diagnosis? Is it support early introduction of symptoms? Is rapid weight gain and maximize the plight of the parents? So it means unpleasant conditions. So you have 20 seconds to answer.
Okay, 20 seconds is finished.
Thank you. So the last two questions, more 50% of the attendants answered this question, and unfortunately, only 25% answered this question. The answer is D. Why D? Because early diagnosis, support early resolution of the symptoms, and rapid weight gain. This is the feature of amino acid-based formula. So why this one? Because if you give the trials of different formula, you want to start soya, you want to start partially, you want to start extensive, so it will make anxious with the parents. So why these doctors try different formula to my child? So this is why they found that extensive hydrolyzed formula it will maximize the unpleasant of the parents, while the other feature will be feature of the extensive hydrolyzed formula. So what's the difference between amino acid based formula and extensive hydrolyzed formula? If you see these two trees, it's the same concept, but one of the leaf and others without leaf. So what's the difference? The difference that amino acid based formula or amino acid formula is the only truly non-allergic formula, while extensive hydrolyzed formula usually is not truly non-allergic formula. Amino acid based formula usually support early diagnosis, support early resolution of symptoms, and has rapid weight gain. So most of the gastroenterologists or most of the allergists, they prefer this amino acid based formula because you will see rapid weight gain compared to extensive hydrolyzed formula. And the most important is minimize the plight of the parents. So the parents would be happy because you use this amino acid formula for diagnostic together with management.
10 minutes, Dr. Mohammed.
Okay. Now, what's the efficacies? We agreed that if the child has symptoms not fully resolved with the extensive hydrolyzed formula, the child has failure to thrive, if the child has multiple food allergy, if the child has severe complex GI food allergy, eosinophilic esophagitis, severe eczema, symptoms with the breastfeeding, nobody argue that amino acid-based formula is better than extensive hydrolyzed formula, especially in this scenario. If you didn't see the scenarios, usually you can start extensive hydrolyzed formula. So I use this one based on my review literatures and by extensive review to what's the overcome between amino acid and extensive hydrolyzed formula. So remember, please, limitation of the milk restricted diet. Once you eliminate it, sometimes you can delay introducing of the solid until the age of the 6 months. Usually I disagree with this one because usually I started at the age of 4 to 5 months, and we should replacement rather than elimination diet, especially risk of nutrition deficiency. Remember, when you put him in cow milk protein free, so you will have high risk for vitamin A deficiency, vitamin D deficiency. If you eliminate eggs, you will have vitamin B12 deficiency, riboflavin deficiency, together with the other food label, especially wheat and peanuts, that has high risk for vitamin E deficiency and niacin deficiency. So most of our patients, I refer them to a dietitian to give more this supplement. The last questions. The pediatrician is following 14-month-old with the mild non-IgE cow milk protein allergy. You are sure the compliance is good, and you want to start to introduce oral challenge test. Which of the following should be started first? Muffin, biscuit, cheese, yogurt. So let's see how's your practice. You can start now.
Okay, 20 seconds finished.
Okay, the answer unfortunately is biscuit. You know why? Because I will show you, we call it IMAP. Yogurt, cheese, this is at the late. So this is why the answer will be biscuit. And I will show you next slide why we start this one. So this is, we call it milk ladders. So milk ladders, usually we call it IMAP, we call it International Interpretation of Milk Allergy in Primary Care. Usually we use it for non-IgE cow milk protein allergy and for mild to moderate symptoms. We ask the parents to start cookies or biscuit. If tolerated, go to the muffin. If tolerated, goes to the pancake. If tolerated, to cheese, yogurt, and the last thing with pasteurized milk and suitable or infant formula. So this is why when you challenge, especially for non-IgE, I'm not talking for IgE, for non-IgE mediated. So this is, we call it IMAP guidance to introduce solid food. What's the relation between cow milk protein allergy and abdominal pain syndromes? Yes, there is some data shows that, especially for these studies, almost 11,000, that they are prone for irritable bowel syndromes, they are prone to recurrent abdominal pain, they are prone to functional constipation. I found a lot of cases of cow milk protein allergy presented with solely with the constipation, in spite of the maximum treatment of laxative. So Prebiotics, Dr. LOIE mentioned that. So just a few light that usually Probiotics, it will stimulate the production of the IgA, and absolutely it stimulates differentiation and growth of the GI mucosa. So this is another study shows how the Probiotics, the gray bars, that the number of the patient accumulating will accept the tolerance, especially for non-IgE mediated, comparing to extensive hydrolyzed formula without Probiotics. I can't skip this one. So at what point the pediatrician refer the infant with the cow milk protein allergy to gastroenterologist or allergist? Diagnostic criteria should depend on intensity of the symptoms. However, if the patient has severe symptoms, referred to the gastroenterologist. And the GI approach usually are invasive and made difficult to interpret, and referral to the gastroenterology or allergy if necessary if the symptoms are severe or persist past 12 months of the age. So this is the last thing, that the ladders usually amino acid based formula. This is why it has rapid weight gain, has diagnostic and therapeutic challenge. They have rapid resolution of the symptoms, and it will minimize the plight and anxious of the parents. So this is why I didn't start in my practice. I don't want to step by one. I go to the amino acid for diagnostic and for treatment. Ladies and gentlemen, my conclusion from this slide that cow milk protein allergy presented up to 3 to 5% in the infant. Cow milk protein divided into IgE and non-IgE and should be differentiated from lactose intolerance. Diagnostic elimination, very important, especially if the child has chronic diarrhea and growth faltering, should be initiated for a limited time, at least 2 to 4 weeks. So don't be hurried that to see the response. And elimination of the cow milk protein in the diet with the breast milk or changing in the infant formula to non-cow milk protein usually eliminate the symptoms. And extensive or hydrolyzed formula is indicated in the cow milk protein allergy, especially if they have patients with the malabsorption. However, if the child is not tolerated, amino acid based formula will be help. Extensive hydrolyzed formula is the first choice from SPGAN, from American Academy of Pediatrics, and elimination of the dairy products have risk of nutritional deficiency and referral to gastroenterology or allergy if the necessary of the symptoms are severe or the persistent beyond 12th of the month. And if anyone is interested, I suggest to read this medical position papers from the GBN diagnostic approach and management of cow milk, and this is usually from the SPGAN GI committee practice guidelines or the expert on the cow milk protein allergy. At the end, I would like to thank you for all listening and see you any question. Thank you.
Thank you, Dr. Mohammed. Thank you so much for this nice presentations and comprehensive actually demonstrations for cosmic allergy and its management. Actually, we enjoy it, you and Dr. also LOIE. Thank you so much. Dr. LOIE, if you come to the stage, please. We have some questions. We'll take some questions and we'll discuss it, inshallah. There are some questions that actually is repeated, but we'll go most of it, inshallah. So this question for Dr. LOIE, if the infant have family history of certain allergy, should the family avoid that certain allergy or start introducing it in small amount and assess the symptoms?
If I understand the question, if the family has a child with food allergy, there should the family should not be avoiding, I mean the new child should not be avoiding any foods. They have to try, and if there are symptoms, definitely they have to stop and test. Yes, A to B is a genetic disease, but it doesn't mean that every child will have cow milk protein allergy. And the other message is you shouldn't be testing a child without symptoms. They have to try, develop symptoms, and then you start the test.
Thank you so much. This question for Dr. Mohammed.
Yes.
In breastfed infant, and he's not actually responding to elimination diet of the mother, what would be the next step?
Okay, this is good questions. Usually, elimination of the milk is not enough. So I ask mom to eliminate other food, especially nuts, fish, egg, wheat, sometimes legumes. If it is strongly restricted on that and still persistent symptoms, usually I switch to the amino acid based formula. So just on the top on the breastfeeding. And most of the times, usually the response, if the mom eliminates not only cow milk, usually if they eliminate other food allergy, usually the response. Almost 5 to 10% they don't respond, so I add extensive hydrolyzed formula.
Okay, good, thank you. So there is one question. I think we came through it. We can also discuss it because some of the attendee are maybe non-physician. But anyway, which is better, breast milk or hypoallergenic formula for infant with cow milk allergy?
It's a self-answer question. So there is no comparison to breastfeeding, definitely. As a matter of fact, there are a few years ago, if we go back a few years ago, breastfeeding in the first 4 months was showing some evidence of allergy prevention. So breastfeeding, there is nothing to compare. Maybe you can compare extensively hydrolyzed to amino acid formula, but breastfeeding, of course, definitely the answer.
Thank you so much.
Yes, agree.
Yes.
Nobody argue, Dr. Dhafer, nobody argue that breastfeeding is the superior.
Yes,
And
yes.
believe me, if we see my clinic and the mom asked to switch, you didn't see how my reaction. Usually I become upset and they say, please, if you want to choose another one, go to other clinic, because breastfeeding is the optimal.
Excellent. Okay, so there is another questions about goat milk, Dr. Mohammed. Goat milk.
Well, this is a tricky. Usually goat milk, when I refute in the literatures, as a treatment, it's no strong evidence on the goat milk. Really, when you see it as there are small studies, a few studies, retrospective, observation studies, but will not convince us that has been rules either in treatment or in prevention. So I don't know about LOIE. Do you agree?
I agree with you. Goat milk was actually studied in few studies, but it is definitely there is number one, there is a cross reactivity. So if you are allergic to cow milk, you might be allergic to goat. Number two, the nutritional value of goat milk is not enough for a growing child. Most of the studies showed that they are either failing to thrive or they are not thriving as needed. So the answer is definitely not. If you need, you can use other amino acid or extensively hydrolyzed.
Okay, thank you so much. There is some thoughts here from Dr. Ahmed Hilal. He said, I think increasing the incidence of allergy is related to medical practice, use of antibiotics, delivery by cesarean section, use of other formulas instead of breast milk. What do you think about this ideas?
You're definitely correct. The same thing about modulating or manipulating the microbiota in the first few years of life. We are discovering more. We are doing more cesarean section. We are using more antibiotics in the first few years of life. Putting in that with a hygiene hypothesis, that is absolutely correct.
Okay, maybe this is the last questions. Okay, Dr. Mohammed, I have one patient actually. He's 4 months. He's atopic child. He has vomiting. He actually seeking a lot of medical services, dermatology. They give him a lot of applicants, and he landed to my clinic. I started him actually on amino acid based formula. He actually get improved from the allergy and also no more vomiting. He start to thrive well. But the problem is he developed severe diarrhea. Watery 7 to 8 times. I wait for him almost 3 weeks and still persistent diarrhea. What do you think?
How old, Dr. Dhafer? How old?
Around 6 to 7 months.
And he's in solid food? Is it regular solid food?
No.
You didn't start it?
No, I don't feel him yet.
So if you are developing diarrhea with these scenarios with the malabsorptive, I would recommend Dr. Dhafer to do sigmoidoscopy. Just look for what's going on. Is it eosinophilic enterocolitis? Is it eosinophilic or food protein induced colitis? And also think about non-IgE cow milk protein allergy. So this is why amino acid based formula in my practice it is diagnostic. So almost 98% they respond. If not responding, usually this is not cow milk protein allergy. So, but if you have developing diarrhea, so if it is 6 months, make sure he's not taking rice with the Cerelac, with the contaminant with the milk, other issues. So if it's still there, so I will recommend to do sigmoidoscopy just to make sure there's no eosinophilic or others.
Thank you so much. Thank you so much, Dr. Mohammed. Thank you so much, Dr. LOIE, for these nice presentations. Actually, we learned a lot. It was actually very interesting. And thanks for all attendees for their questions and their actually interactive involved. And actually hopeful there is some we'll send it to you actually to evaluate for the attendee to evaluate this activity. And actually we have 2 more webinar included in this web series. We'll announce it later inshallah, maybe after Eid inshallah. So thank you so much, and actually I would like to thank also the organizing committee, Dr. Ali Muhaidel, Dr. Muad Treki, and all SASPIGA members. And finally, I would like to thank the Nutricia company for sponsoring this event. Stay tuned, inshallah, and see you, inshallah, in the other webinar. Thank you so much.
Thank you. Thank you.
Yeah.